name is Shailesh Singh and you are listening to CardioAid. So today we'll be talking about the Flower MI trial which was published in May 2021 edition of NEJM. So what we know is 50% of patients with acute ST segment elevation MI have multivessel disease. What we already know is that preventive PCI or performing the complete revascularization in ST segment MI patients decreases the rate of cardiac death and non-fatal MI and subsequent angina. The current guidelines recommend complete revascularization in the setting of STEMI. The 2018 ESC guidelines of the myocardial revascularization give a class 2A recommendation for routine revascularization of non-infarct related artery in a patient of multivessel disease before discharge. 4 randomized controlled trials have already shown the benefits of complete revascularization in patients with ST segment elevation MI with multivessel disease. These 4 trials include the PRAMI trial, CULPRIT trial, DYNAMI 3 Primal T trial, and COMPARE Acute trial. One thing I'd like to mention here is the complete revascularization is recommended in patients of ST segment elevation MI except in the setting of cardiogenic shock. The DYNAMI 3 Primal T trial and COMPARE Acute trial have shown that in patients of ST segment elevation MI with multivessel disease, FFR decreased the composite of death, MI, and revascularization. And this was primarily driven by decrease in repeat revascularization. Death and MI were similar in both angiography group and FFR group in both the trials. What we clearly understand from these data is that FFR decreases the rate of repeat revascularization in patients of ST segment elevation MI with multivessel disease. What is still unknown is whether FFR guided approach in such patients improve clinical outcomes compared to the angio alone. Flower MI trial was a multicentric randomized open label trial which was conducted from December 2016 to December 2018 in France. Patients of ST segment elevation MI who were more than 18 years of age and had undergone successful PCI of infarct related artery. Infarct related artery PCI could be primary PCI, rescue PCI, or a pharmacoinvasive PCI were enrolled in the trial. The successful PCI was defined as TIMI score of more than equal to 2 or residual stenosis less than 30% for a culprit lesion. The patient had to have a major epicardial coronary artery or a major side branch more than 2 mm in diameter with at least one lesion of more than equal to 50% stenosis. Patients were excluded if they had single vessel disease or they had hemodynamic instability, had previous cardiac surgery, or had coronary artery calcification, or they were having CTOs, or they had failed culprit lesion PCI, or the patients were referred for CABG. Patients were randomized to undergo complete revascularization guided by either FFR or angiography. In the FFR group, the FFR was measured if the visual estimation revealed a stenosis of more than equal to 50%, and FFR of less than equal to 0.8 was considered clinically significant. Although the protocol encouraged the complete revascularization during the index procedure, more than 95% patients ended up having a separate stage procedure for complete revascularization. The follow-up was conducted during an OPD visit, which was scheduled at 30 days, then at 6 months, then 12 months, and then 30 months after primary revascularization. If the patients could not attend the OPDs for any reasons, then the patients were contacted by mail or telephone. The primary outcome was a composite of death from any cause, non-fatal MI, or unplanned hospitalization leading to urgent revascularization at 1 year. The secondary outcomes included procedure time, total amount of contrast used, and individual components of the primary outcome like any revascularization urgent or elective, urgent revascularization of any non-culprit artery, rehospitalization for angina or heart failure, any rehospitalization in the cardiology department, and functional class as per the Canadian classification of the angina. Number of anti-anginal drugs and cost effectiveness were analyzed. A total of 1170 patients, that is close to 1200 patients with STEMI and multivessel disease were enrolled in the study, out of which close to 600 got enrolled in the FFR group and close to 600 got enrolled in angiography guided group. The baseline characteristics of the patient population in both the groups were comparable. Mean age of the patient was 63 years, 15% of the patients were females in both the groups, approximately 45% patients in both the groups were hypertensive, approximately 18% of the patients in both the groups were diabetic. Dyslipidemia was present in approximately 40% patients. Less than 10% of patients had history of previous myocardial infarction. approximately 10% patients had history of previous PCI. When the location was analyzed, it was found that approximately 60% of the patients had inferior wall MI and roughly one-third patients had anterior wall MI. And on the angiography, approximately three-fourths of the patients had double vessel disease. The median left ventricular ejection fraction in both the groups was 50%. Approximately 66% patients in the FFR guided group had PCI, as compared to 97% patients in the angiography group received PCI. The mean number of stents for non-culprit lesion was 1.01 in the FFR group, whereas it was 1.5 in the angiography guided group. Drug-eluting stents were used in 99% of all the patients. What the trialists found was, among the patients with ST segment elevation MI with multivessel disease who had undergone successful PCI of the infarct-related artery, an FFR guided strategy for complete revascularization was not superior to angiography guided strategy for reducing composite primary outcome, which was death, non-fatal MI, and unplanned hospitalization. The individual components of this primary outcome, as well as the other secondary outcomes that are discussed previously, did not differ between the two groups. If you would recall, you'll remember that Dynami 3 Primalty trial and Compare Acute trial had shown that in patients with ST segment elevation MI with multivessel disease, FFR had reduced the composite of death, MI, and revascularization. However, this was primarily because of decrease in repeat revascularization. The results are in complete contrast with the FAME study. The FAME trial found that in patients with stable CAD, there was a lower incidence of major adverse events when FFR was used as compared to the angiographic PCI at 1 year. The results of FAME trial are completely different from this Flower MI trial. This could be because of the difference in the type of patient enrolled in both these studies. The FAME trial included the stable CAD patients, and this Flower MI trial included the acute coronary syndrome or the ST segment elevation MI patients. The FFR may not be a very good investigation for patients with ST segment elevation MI. Why? Because the natural history studies have already shown us that most of the ACS, it results from rupture or erosion of thin fibrous cap which overlies an atherosclerotic plaque. And there are often such several plaques in the entire coronary tree in patients with ST segment elevation MI. A plaque at high risk of occlusion need not be obstructive to flow. For example, if we look at the data from the Prospect trial, there were total 106 non-infarct artery lesions which were determined to be responsible for subsequent serious cardiac events in follow-up of patients of acute coronary syndrome. And in these patients, mean angiographic stenosis was only 32%. Patients with STEMI may have multiple ruptured plaques that have little effect on flow. Therefore, they are underestimated by FFR in their potential to cause subsequent MI or cardiac death. It was encouraged in the trial that the patients undergo complete revascularization during the index procedure only. However, more than 95% patients in the trial ended up having stage revascularization. Now, there are advantages and disadvantages of having this stage revascularization in patients with MI. The advantages of the complete revascularization during the index procedure are that patient is spared from a second procedure and all its adverse effects, and at times the second procedure will be undertaken and no intervention will be performed if FFR is non-significant. So this complete revascularization during index procedure spares the patient the second procedure. However, there is a disadvantage which comes with complete revascularization during the index procedure, and this is that revascularization and FFR assessment during the index procedure might not be the best idea because of the vasospasm. It can increase the stenosis severity, leading to an overestimation of stenosis severity assessment. The validity of FFR in the patients with acute MI, especially acute anterior wall MI, is debated. Based on the results of this trial, either an FFR guided or a CAG guided revascularization strategy are acceptable choices for management of residual CAD after primary PCI in patients with ST segment elevation MI with multivessel disease. We were talking about Flower MI trial published in May 2021 edition of NEJM. Thank you for listening.